Good evening. Good evening. A warm welcome to this evening webinar, morning session on some parts of the world. A warm welcome to each one of you to this digital CME, digital webinar on bariatric and metabolic surgery in COVID era. There's a lot of new normals that have crept in to see how we go ahead and treat these patients with morbid obesity and patients who are coming for metabolic surgery. So actually we have a host of speakers of international repute who are joining us from across the globe and who are going to share their experiences from different parts of the world and different perspectives. So before I hand this over to Abhishek, who is going to conduct the entire proceedings of this webinar, I thought I should thank the concerned societies. Can I have a slide, please? The four societies which have gone out of the way to give support and extend support to this webinar that we are doing this evening. ELSA, the Endoscopic and Laparoscopic Surgeons of Asia. I sincerely thank the entire executive of the ELSA for endorsing this meeting. The second society that has endorsed this meeting is the IBC, or the International Bariatric Club, the University of Oxford. Sincere thanks to all the executive members of this society. The third society which has endorsed this webinar is the International Excellence Federation for Bariatric and Metabolic Surgery, IEF as it is abbreviated. Thanks again to all the executive members, Executive Council of IEF. And finally, we have the Obesity Surgical Society of India, which has also endorsed this webinar. Before I go on to this, the actual presentations, I thought I'll just share with you a couple of slides as to why we are doing this presentation today evening. Now, we are doing this presentation, we're doing this webinar basically because there are a lot of apprehensions, a lot of guidelines that have come in from across the globe regarding the surgical practices that have to be followed. So, bariatric surgery, one of the surgical specialties, no different from other surgical specialties, but there are some differences in how bariatric and metabolic surgery is practiced. So we thought we'd go into the details. So basically, if you see, obesity and severe obesity was significantly more prevalent among the patients with COVID-19. So this is the data that has come in recently to show that it is almost about 47.6% and 28.2% versus 25.2% and 10.8%. This is significantly different. So these patients are more prone. And you can see this, all these patients who have more than 35 kg per meter square BMI, these patients have a 7-fold increase of mechanical ventilation. This is also, we have a lot of evidence to show that these patients require increased risk of mechanical ventilation. And also we have other data that is coming in from different parts of the world regarding the various protocols that we have to follow, various risk factors that are associated with bariatric and metabolic surgery. So I thought we would share this with global leaders from across the world. So I'd asked Dr. Abhishek, who is the Associate Director of the Division of Metabolic and Bariatric Surgery here at AIG Hospitals in Hyderabad, India. He would conduct the proceedings and he would take forward the various presentations, and after that we'll come back to the questions and answers that we're going to take from the participants who are participating in this webinar.
So, very good evening and very good morning to the US, Dr. David Cumming, who has joined us. Thank you for joining all of us, and you can see that you can ask the questions on the comment box on YouTube, and we'll be happy to answer your questions. The first speaker we have is Dr. Jaideep Rao from Singapore. He is a past president of Obesity and Metabolic Surgery Society of Singapore. He is a president of Singapore Hernia Society, and he is a senior consultant surgeon at JR Surgery Clinic at Mount Elizabeth Nova Specialist Center, and he's a good friend of mine. I would request Dr. Jaideep to start sharing his screen and start the proceedings. Thank you.
Can you see the screen?
We still see you, Jaideep.
Share your screen.
No. Okay. Now?
Yes.
Okay.
There you go.
Go to the presentation mode.
Okay.
Yes.
Yeah, absolutely.
Okay, perfect. Okay, good evening, everybody, and good morning to some places in the world. And I'd like to thank Dr. G.V. Rao, Dr. Abhishek, for giving me an opportunity to share our experience from Singapore with all of you. And it's truly a privilege to be part of such a star-studded speaker portfolio. So it's a great topic again, COVID and bariatric surgery, the new normal. And I've been asked to speak on the association of obesity, whether obese patients are more contagious, and what its link with COVID is. That will be the first part. And the second part will be some if so and ASMBS guidelines that will take us through. So what we know for now is that, of course, this COVID-19 has, started in China, spread globally, and has caused a pandemic. What we also know is that obesity has been previously recognized as an independent predisposing factor for severe H1N1 pulmonary infection. And now the relationship of COVID-19 and obesity is still unclear, and there are some emerging data from it. So this is a French study that looked at obesity that was very frequent in a cohort of patients admitted to the intensive care, 47%. The disease, of course, if your BMI was more than 35, the chance of you getting a severe disease, 87%. And the need for invasive mechanical ventilation was also associated with severe obesity, was around 68%. And this was independent of age, sex, diabetes, hypertension, and other comorbidities. So what's going to change in the future is that currently in this epidemic, we have to be really careful of these obese patients, and we'll treat them as a high risk, just like the older age individuals, and they have to be monitored much more closely. Now, this is from New York, the data that patients who had BMI of between 30 and 35 were 2 times more likely to get admitted to the acute care unit compared to BMI less than 30. And those with BMI more than 35 had a 2.2 times risk of getting into an acute care, and 3.6 times higher to get into a critical care unit requiring ventilation. And this is quite disturbing. Now, what is this relationship, and what is the reason for this? Of course, there's an increased prevalence of obesity. So we're actually looking at a pandemic within a pandemic. And this adiposity, which undermines the pulmonary microenvironment, wherein the viral pathogenesis and immune cell trafficking could contribute to this maladaptive cycle. There's also a relationship of vitamin D deficiency, and I think there's going to be a speaker who's going to talk about it, so I'm not going to elaborate further. There are various mechanisms, obesity, which is causally related to hypertension, coronary heart disease, and also potentiates these cardiovascular risk factors. Obesity also leads to impaired insulin resistance and reduced beta cell functions. This we know. And what happens is that the COVID-19 virus, now we're looking at it, it acts on the ACE2 inhibitor cells and has a direct disruption of pancreatic beta cell function. It causes obesity, like an inflammation that causes thrombosis, and this results in prothrombotic DIVC rates to be much higher. Why do we think that the important word used was contagious? And viruses, they express tropism for different types of tissue, and in this case, adipocytes. So COVID-19, they work on the ACE2 receptors, and these are adipocytes. And in obese patients, the adipocytes are, of course, increased in number, and therefore they have a higher chance of getting this infection. Once they get this infection, they also have a higher chance of making it severe. And that is because of this excess fat that is associated with complement system overactivation can result in a cytokine storm. and this can make it worse. And in obese patients, there's also a high viral load, and therefore they can be more contagious to other patients and also other obese patients. So that's where the link between COVID and obesity, and especially whether it being contagious, it matters. So you can see this mechanism. I'm going to leave this slide on here for people to see because it's quite busy and we don't have a lot of time. Via the lungs, increased cardiorenal stress, and also immune hyperactivity. So all these three things with comorbidities results in a severe course of COVID. Now, quickly running through some of the recommendations from both IFSO and ACS. The general recommendations from IFSO and in general is that all elective cases should be postponed during the pandemic, because this we need to minimize the risk to both patient healthcare and minimize potential exposure to unsuspecting patients. Of course, you all know the screening and diagnosis, body temperature check, routine CT scan and RT-PCR, as well as pharyngeal swab, isolating patients while waiting for these tests, and of course, those patients who have a history of symptoms and travel, they all need to be taken care of. Now, only emergency surgeries and complications of bariatric surgeries are recommended during this outbreak. Now, how do we decide what is what? Again, I'm going to leave this here. Emergency cases, for example, perforation, septic shock, bleeding, etc. Urgent cases may be things like severe stenosis, severe GERD, and elective are primary bariatric surgeries that are waiting in line. So you can divide it into three cohorts: cohort A, cohort B, and cohort C, where cohort A is suspected or confirmed COVID patients. Cohort B is those who are under quarantine, who have been closely associated, and cohort C are confirmed without infection. So this is the guidelines that when a patient comes in as emergency, if they're cohort A, if it's elective, you can postpone. If it's emergency life-saving, use level 2 or 3 PPEs, and you can do. If it's cohort B, you can follow this algorithm. If it's suspected, then you postpone. If it's not, then you can continue the surgery with level 1 PPE. Now, what are the levels? I'm leaving it here again for you to see level 1, 2, and 3. Use this guideline to help you in preparing your armamentarium against COVID. A special mention to laparoscopic surgery is recommended in laparoscopic surgery when you're doing, and especially bariatric is all laparoscopic surgery. Keep your intra-abdominal pressures low, avoid rapid desufflation, and the surgical plume needs to be deflated in a closed vacuum, and I'll tell you how. In Singapore, we use this system. It's called the smoke evacuator system, Rapid Vac. It's connected, and it's an ALPA filter, ultra low particulate, which cleanses 99.99% filtration, including the COVID virus. If you don't have that system and it's expensive, you can devise your own system, a tube like this. I connected the drip set to your port. This is connected to a water seal and a closed evacuation system. So these are some things very important that laparoscopic people can do to minimize risk. Again, these are the guidelines after operations. If they are COVID suspects, they need to go to isolation. If they're not, then you make tests to make sure that they are not before discharging them. Usually, we do 2 sets of tests to make sure that they are negative. I'm going to quickly go through this. What about patients who have recovered from COVID requiring bariatric surgery? At the moment, they should be assessed by a multidisciplinary team. Diet and lifestyle should be advised before surgical treatment, since we still don't know the long-term effects or complications of COVID-19. A checklist from AMBS. These are the 10 things that you need to check, mainly awareness, preparedness, patient issues, and safe and high-quality care to be delivered. In terms of awareness, it's important to know the prevalence of the COVID in your country, in your place, and in your hospital too. And you should have at least 14 days. If you're planning to start elective surgery, you should have your curve on the downward trend, ideally at least 2 weeks of no new cases. Know that how many tests are available. Important that you have all your PPE policies in place, and you make sure you have enough healthcare beds, ICUs, etc., and supply. Your workforce staffing is very important, and you need to divide your team into 3 teams. One team that will take care of COVID patients, one team that will take care of non-COVID patients, and the third team is going to be standby. None of these 3 teams should be in touch with each other, so that if one team goes down, then the other team can come in and take its place while this team recovers. This is very important, and you have to cut down your list to at least half to 20% to be able to give variances. Patient issues, you all know, and it's important to have a delivery of high quality care, and we divide these into 5 phases: preoperative, immobility. So in terms of preoperative care, if you're planning to do elective surgery, what we do is get a test to make sure they're COVID negative. After that, they go into a quarantine or home stay for 2 weeks, after which they get retested negative before going for surgery. And after surgery, it is preferable to discharge them back to their home for another 2 weeks of quarantine. If they go to nursing home, etc., it's not the ideal because they have a high chance of getting infection from other patients. We can use a thing like the MENS score. Now, what is a MENS score? It is medically necessary time-sensitive scores. It has procedure factors. We give them points depending on time and the need for post-op, etc. Disease factors, if you were to impact of delay for 2 weeks, 4 weeks, 6 weeks, as well as patient factors, whether how old they are, comorbidities, and depending on that, you can give them these points. If it is low point, you can go ahead. If it is high points, then we should postpone the surgery. So just to recap on the important tips, elective should only be done when the national curve has flattened and on the downward trend, ideally 2 weeks of no new cases, and beware of the second wave. In many countries, the second wave has come up. I'm going to move this in events of time, and I'm going to talk about the statistics later. So thank you very much once again.
Information in a very brief talk. In fact, IFSO and ASAM based, most of the guidelines are almost similar. And we will have a question answer session at the last after the panel discussion. Meanwhile, we'll move to the next speaker, Dr. C.K. Huang. Dr. C.K. Huang is the Superintendent of Body Science and Metabolic Disorder International Medical Center, China Medical University Hospital, Taiwan. He is a founding chairman of IEF, and he has performed more than 5,000 operations for severely obese and diabetics. And in fact, he has many awards and many, thanks for himself. He is the first person in the world to do single incision transumbilical Roux-en-Y gastric bypass. He is the first person to do laparoscopic gastric banding, and he is the inventor of loop duodenojejunal bypass procedure. I welcome you for this presentation, Dr. Huang. Thank you for joining us. You can share your screen and go ahead.
Okay, thank you. Good evening, everyone. I think that it's a good time for us to have some discussion. I hope that you can hear me very well. I'm still in the OT, so you can imagine that I'm still doing elective bariatric surgery till now. So today I was assigned by Abhishek about to talk 2 pandemic myths. So I'm going to talk about the obesity in COVID-19 period. There's some presentation material from my fellow Anand Patel. He now is in the OT. So okay, so I'm going to start. Still again, I want to thanks again for the invitation. I want to say this is the announcement from our government today. There's no local case in consecutive 46 days in Taiwan already. So in Taiwan now, our CDC reports even today there's no new confirmed cases. So Taiwan now has been very safe. That's the reason why we still continue to do elective procedures in Taiwan without any limitations. and almost 90% was imported from international guests or some Taiwanese, but most was quarantined for 14 days. And those who get infected, they will stay in the hospital till the test is negative. Okay, so this is the condition in Taiwan. I would like to say for severe infection from the COVID-19, you will see mostly is about 5%, but for the mortality in the world is account about 3 to 5% for the mortality rates. But in fact, mostly 8% is not severe disease. So we want to know whether it's really any risk factor to develop this kind of severe problems for that. Okay, so in fact, there's been a few papers talking about risk factor for severe disease or even cause mortality. I think there's a few factors. One is age, then is those who have diabetes, and very interesting is that those who is overweight or obesity is also very high risk. And heart disease and hypertension, cardiovascular problems, or those who are smoking and blood type and all genetic factors. I would like to talk about the first three factors. One is age. For those, about 8 out of 10 cases associated with COVID-19 in the United States occurred in adults more than 65. So the risk of the infection, including the need hospitalization and ICU care, most is increased significantly with the age. So those who are more aged, they in fact have more possibility to cause the severity. I think in the whole world, including China and including like the report from France, all they shown the same. So the immune system in old age seems is the main reasons to have the problem of the infection. Number two is about diabetes. Diabetes also linked to the risk of more severe type. In the review of a meta-analysis recently, diabetes almost nearly 3 times more like to have a critical case of COVID-19 or even die from the disease. Compare those who they don't have the underlying health conditions. And another paper published by China, they show the blood sugar levels in this period, those who get infection. By those who can get well-controlled sugars seems has less severe disease too. So even you have diabetes, if under control, in fact, you don't cause severe problems. Another one is obesity. BMI really matters in COVID-19 infections. There's one study analyzed the groups, those who in United States, showing that in compare with non-obese patients, there's 2 times to be admitted to the critical care. It means ICU. Okay, and another from the China found that COVID-19 patients are more the same, about 2 times to develop severe type compared with the normal weight one. So those who are overweight or even not obese, about 86% more risk to developing the severe pneumonia. Then another one in France showing that half of the patients was almost is obese. So even in the young age patients, it's showing that the BMI 30 to 35 is about 1.8 times higher the risk to go to the critical care. Those who BMI higher than 35, it means the morbid obese patients, they are almost 3.6 times higher to compare with the BMI less than 30. So the BMI higher, it means the patient is really more dangerous to get severe pneumonia. So this is the figure showing that those who need the mechanical ventilations, most of they are quite obese. And compare with the different category of BMI, higher BMI, then they have more severe infection, need the mechanical ventilation. So that's the reason why I say the BMI really matters during the COVID-19. So very interesting is that when these two pandemics meet together, the severity of ICU admission increase in the increase of the BMI, and obese persons most should have extra precaution to avoid contamination with COVID-19. So when they get disease, they are easy to get a more severe type. the patient with severe obesity should be monitored more closely. But what is the cause of obesity? Patients can have more problems in COVID-19 infections. Number one is about that they have more adverse cardiopulmonary functions. I think for all the bariatric surgeons, you understand the function of the heart, including airway, including the lung capacity, in fact, has more difficult, more worse in the morbid obese patients. So this is about organ function. But in fact, there's been a few studies showing that the obesity and metabolic syndromes has a lot of effect on the immune systems. So in this study, you will see even 4 years ago, there's been a lot of studies showing that in obese humans or diabetes humans, or those who with high obesity prevalence communities, the risk of the influenza is increased, the vaccine of influenza is failure is higher, and those who influenza-related complication and hospitalization is high. So it's not a new thing that obese humans, persons can have more severe disease when you get infected by the virus. So the metabolic pathway for obesity and COVID-19 infection, there's been some scientists postulate some theories. It goes through the ACE receptors to cause the more glycemia and also cause some more possible infection complications. So this is a simple summary about the COVID-19 and inflammation. It causes a few aspects. Number one is hypoglycemia. From the obesity, they will cause the beta cell function dysfunction. Then DPP4 receptor affinity from the virus, or the stress induced the serum cortisol levels and leptin and insulin resistance. So the hyperglycemia cause more affinity to the infection. Then the adipose tissues cause more hypertension from the ACE inhibitors. So the ACE receptors can increase impression of the receptor, further promote the virus entry the cells. Another issue is that mostly we know the chronic inflammation. So adipose tissue drives some interleukin 1 and 6 and TNF alpha and inflammatory triads cause more chronic inflammation and change the permeability of the cell to the virus infections. So in the obesity patients, they have hyperinflammation, it causing those with poor T function, T cell function, macrophage functions, reduce antiviral response, and also increase the viral shedding and subsequent transmission of virus. So there's a lot of factors that in obesity, from the organ to all to the metabolic pathway and go to the molecular pathway and all to go to the immune function. That's the reason why obese patients, they have more prone to go to the severe disease. And what is the main reasons? The molecular pathway has been shown leptin might be the very important factors. These hormones, because of in obese patients, they have more resistance. So this leptin cannot modulate the immune function very well, including the innate immunity and adaptive immunity. So after this, I want to share some experience in Taiwan about our elective bariatric and metabolic surgeries. This is the paper published in IFSO showing that they give us a suggestion in April showing don't do elective bariatric and metabolic surgery in the world to the IFSO membership for all the countries. But in fact, in Taiwan, the government did not set any limitation since starting to find the COVID-19 infection from Wuhan, China. So I'm going to show you some data from our centers from this year, the first season till now. So, but we have some flow chart for healthcare workers in our centers and in our hospitals. So in fact, including the healthcare workers and including the patient, we can enter the hospital only with one designated entrance. Then in there is a thermal scanner and individual temperature. So those who have fever, they cannot come in. Those who have symptoms of the upper airway infection, they cannot come in. Those who have cross contact with COVID-19 confirmed case, they cannot come in. So when it was clear, then we can go to the hospital to start our working. Okay. Then the flow chart for elective bariatric and metabolic surgery patient. In fact, they have the same flow chart, very similar to a health worker. But before surgery, we have a lot of checkup for them. But we don't routinely doing the COVID-19 test for all the patients. About the thermal check and including the travel history, including the some serious study before the surgeries. When it's all negative, we would do bariatric surgery for them. Okay. So from January to April this year, so you see, compared with last year, in fact, the case loss is very similar. Not much difference in the first months, but in April there is some drops because of some economic impact. I think because of a lot of patients, they cannot afford the surgery because of some patients, they cannot get the work in the regular work as what they do before. So sometimes the salary is not go to the pocket. So in April, there is some drops, but from May, it seems it's come back again. So I think there's no much change in that. So from these 2 years, you will see the number for the 4 months is last year is 117, this year is about 99 for these 4 months. There's only about a 15% drops in the surgical months in our centers. Okay, so any complication from these elective procedures, in fact, we don't have any cases after surgery, development of fever or unknown, or those with upper airway infection, or those who need the COVID-19 test. But we have one complication, about 1% from the sleep with Cushing syndromes. Those he have developed leak after 4 days after surgery, was successfully managed by reoperation. We don't have mortality in this series. There's no difference on length of stay for both groups. So here I'm going to set a conclusion for my talk. Obesity and metabolic syndromes worsen the condition of COVID-19 infection because of impaired immunity, and poorly controlled disease might carry even higher risk. There is no still any evidence showing that bariatric patient in COVID-19 pandemic is really safe, but it should, and we also should warrant surgical stress might impair immunity shortly. So personally, I recommend bariatric surgery only improved clearance of community infection area or country. Those who still have the COVID-19 endemic area, I think to do bariatric surgery, I think it would be better to follow the IFSO guidelines. We still need more study and observation if we want to restart the bariatric practice in the world. Okay, thank you. It's my talk.
Thank you, Dr. Huang. When Corona meets or COVID meets obesity, it's called, I call it coracity. And thank you for giving us ray of hope. And I really like that Taiwan has already started bariatric surgery, and it's a really optimistic approach for all of us. The next speaker we have is Dr. Suthep from Thailand. He is Associate Professor of Surgery at Chungkum University, Bangkok, Thailand. He is a Director of Chula Medical Minimal Invasive Surgery Fellowship Training Program and the Center. He is the President of ELSA and President of Endoscopic Surgeons of Thailand. He is a President-elect of APM BSS, and he is a past Congress President for ELSA, which was held last year in Thailand. I would like Dr. Suthep to please share his screen and start his talk. Dr. Suthep?
Thank you very much. Thank you, Abhishek. Good evening, everyone. It's my pleasure to join the panel, and my topic would be the bariatric and metabolic surgery in era of COVID-19. I'm going to share to you our Thailand experience. Before I getting started, I would like to say that I do respect the policy and also the measure that each country's government has been implemented to the country, and I believe that it would be fit to the country. For us, for me, myself, this is the experience from Thailand. which might fit to some country but might not fit to others. But anyway, I enjoyed the talk from Taiwan experience, CK. You haven't stopped the bariatric surgery. Have a look on my presentation. Actually, for Thailand, we do have 39.8 tourists visiting in 2019. Out of those, 11 million were Chinese. So then when it was first infected in China, the government has been very carefully observing, but no doubt for the first case outside of China was in Thailand. And we follow carefully. You will see that most of the cases would be the imported cases from China until number 16, which is the end of January, that we found the local infected case. And you may see that in February started, and March, the crisis has been coming to Thailand. So when it touched number 100 cases of coronavirus in Thailand, our Chula BMI, the Bariatric and Metabolic Institute, has been temporarily suspended to prevent our patient and also to reserve the resources to fight with the COVID-19. We started, the government have declared the emergency situation in the whole area of the Kingdom of Thailand on March 26, and following by the Center to Control the COVID-19. So if we follow, we do not think the percentage of the increasing at 33% would lead us to 50,000 cases in the early April. So what the government and all the society has been discussing is that we have to flatten down the curve to not to be over the capacity of the medical care. And several measurements have been implemented. Then you can see that it started early March and the number is shooting. Luckily, at the declaration of the emergency on 26, we also did have the curfew from 10 p.m. to 4 a.m. That would help very much, and almost all the people are requested to work from home. You will see that the mask wearing it adopted in any society. This is the number to show to you is that the blue curve showing the mask wearing percentage, which is 91%. I believe that this is very much important to flatten down the curve. And also hand wash following by the red color, 83%. So this is very important. And of course, we switched to the online activity. The social distancing is very important and it is implemented everywhere. This is our cafeteria. Even in the escalator, you have to do the distancing. Then what we as a surgeon and the medical personnel have to be taken is that first phase, I would say, we've been very much alerted, following very closely. You will see that the number is increasing slowly, but when the pandemic comes, the number is increasing. What we have to do, you can see that we have to suspend all elective cases. We have only the emergency cases, cancer or urgency. Those will be allowed to be in the theater. And you will see that we reduce our capacity of the cases in the theater to 50%. To be able to manage the resources and risk. The question at that any time is that when to start again the elective cases. As shown by Jaideep, you see that after the flatten down of the curve or after the peak, that will be the point that we should be considered. Have a look on the experience of Thailand. We do have the whole country number, and also this is the number from my hospital, King Chulalongkorn Memorial Hospital. You will see the number of cases, the red one showing the active case, which is the admitted case. The maximum that we did have was 60 cases, and the green one is showing the recovery. And then what we have seen is that when we we flatten down the number of admission down to half. I would say about 30 cases. We've been considering the reopening the elective cases. We call this transitional zone. And what we have do is that you have seen that the OR schedule has been increasing to 75%. We keep 25% in case that the pandemic has been increasing again or the second wave has been hitting. So what we have, you can see that outside of emergency or cancer cases, now we can do some functional or non-cancer cases. Also bariatric surgery, it's eligible in this phase, but we do need to prioritize the patient, all the patients who do need the operation urgently, so we can do that. At the same time, you will see that because we have the lockdown, this phase in the economic part, it's been eased for the lockdown, started on the 3rd of May. Then as a society, EROSA has been initiating several webinars regarding the MIS at the time of COVID-19, or how to do the laparoscopic endoscopic guideline during the COVID-19. We here in Thailand also, the laparoscopic endoscopic society, Surgery Society of Thailand also having the webinar, and also we doing the guideline. This guideline has been very much helping us. This is to how to prepare to start again, because we stop our bariatric and metabolic cases. Today we start the webinar trying to have a guideline suiting to our society. Now you can see that started from last week, we have started the elective cases, and we can return to our capacity of the schedule in the theater with very careful and highly alert and monitoring. And those who will be doing the operation during the post-pandemic phase have to be undergone the COVID-19 test, as mentioned by Jaideep. And we do hope that now the number is still, you can see from the curve, we hope that the curve is still flattened. We are very much carefully observing, monitoring that it might have the second wave. But anyway, what we have seen now, it was number of the case would be the coming from the quarantine for those who are coming from, returning from outside, which subjected to state quarantine for 2 weeks. This is the, I would say it might be my conclusion, the experience from Thailand, which you can see the daily cases of infected COVID-19 in Thailand. It started in the second half of March that the pandemic has increasing, and we've been dealing with this situation for 6 weeks until the early May that we can be returning to our elective case with very much highly the prioritization to categorize the patient to be subjected for the operation. And last week, we can do the elective cases with almost nearly normal what we have done before with the COVID test before the procedure. Ladies and gentlemen, my colleague, I think from experience from Thailand, I would say that we need to be very careful, observe, monitoring the infection cases in your local place and the facility and also resources that you have been reserving for the COVID-19. But anyway, we do need to return to our activity. So I would say that COVID-19 is still challenging because we don't know even now what it's going to be, especially in Thailand or in other countries. It's still going on. Number two, I think it's correct that bariatric and metabolic surgery is subjected to be suspended at the very early pandemic phase to be able to reserve the resources to deal with the COVID-19. And if we would like to start again, it must be very careful to be start the bariatric and metabolic surgery. I would like to thank for your attention. Thank you very much.
Thank you, Dr. Sutep. That was very insightful, and probably I think India and Thailand are on the same track, and probably both the countries will get rid of this coronavirus as early as possible. So we move on to the next speaker, Dr. Kasama. He's from Japan. He's the Director of Weight Loss and Metabolic Surgery Center, Yutsuya Medical, Tokyo, Japan. He's the President of IFSO APC. He's the immediate past President of APM-BSS. He is the Executive Board of IFSO, and he is an Executive Board of Japanese Society for Endoscopic Surgery and Japanese Society for Treatment for Obesity. I welcome Dr. Kasama. Please share your screen and start your presentation. Dr. Kasama?
Yeah, your screen is on, Dr. Kasama.
Yeah, it's still muted. Sorry, it's still muted. Can you hear me?
Yeah, we can see you and hear you.
Okay, that's great. So thank you, Abhishek and Dr. Lau, for giving me opportunity for talk about these interesting topics. This topic is a little bit controversial, and but it's really interesting. And before talking about these topics, I would like to say that Japan government just lifted the state of emergency yesterday, so that we are not fully but almost recovered from the damage of the COVID-19. So that our topics, I will talk about the detail of Japanese situation later. And the topics today is what are the lessons to be learned from previous influenza virus infection in obesity. As you know, this is a very old poster in Japan. The first lesson we have learned from flu was from Spanish flu. This poster was in 1922. It's almost 100 years ago. And at that time, more than 380,000 of Japanese people died in Japan. And this poster showed that we must wear mask in train and also in front of people. And the washing hand and the gargling is also recommended in 100 years ago. And also we start to blame the someone who don't use mask in train. So that that said that reckless without mask and don't underestimate flu. It was 100 years ago, the poster in public. That's quite interesting. So this is the first lesson we learned from flu. And we have to think why we should have to stop bariatric surgery in the COVID-19 pandemic. We have three reasons. The first one is to reserve medical resource for pandemic, like a PPE and the human resources. And the second one is to prevent medical staff from infection. And the third one, this is my topic, is to avoid COVID-19 infection of post-bariatric patients. As many of you know that this is very important paper from our friends, Dr. Alinian in Cleveland Clinic. This told us that the very high mortality ratio of the COVID-19 patients after surgery. This was very scary to us, so that we thought we have to stop bariatric and other surgery immediately. As CK1 said that we have immunosuppression of obesity. Obesity and especially flu is the most popular viral infection. is one of the biggest risk factor of influenza as well as the COVID-19. Of course, as Sike said, surgery-induced immunosuppression. Many papers said, and also when we are a medical student almost 30, 40 years ago, we were taught that the surgery is induced trauma. So that kind of things may cause immunosuppression in just after the operation. Yes, theoretically, yes. But how about the clinically after bariatric surgery? So if bariatric surgery causes immunosuppression, so is that flu increase after bariatric surgery? We checked some paper. It's only one paper. This is just an abstract. The effect of bariatric surgery on influenza-like illness in morbid obese patients. So this is a case match study in Italy, and there was a significant difference of reduction of the influenza-like illness in bariatric surgery patients after surgery. And in control group, higher symptom scores and longer sick leave. The result, the treatment of morbid obesity through bariatric surgery significantly reduced seasonal influenza severity. For that, we have to think of the risk of obesity. Of course, obesity has a big risk of the infection, but we also have to think the risk of the postponed bariatric surgery. So we should uniformly stop bariatric surgery or think of risk and benefit of that procedures. And if the obesity risk is bigger than bariatric surgery risk, it's possibly bariatric surgery may be recommended after, not at the peak of pandemic, after the peak of pandemic. But I have a question to all panelists. So, do you have a COVID-19 patient after your bariatric practice? The first one. The second one is, have you experienced the increase of flu infection during a flu season in the winter after bariatric surgery? In my personal experience, I feel that the flu infection is less than usual than after bariatric surgery, even in the flu season in Japan. So that I would like to have your opinion regarding this issue. Thank you, Abhishek. So that can you ask the question to all panelists? Abhishek?
Panelists can see
Hi.
these questions.
Hi, thank you very much, Kazu. Question number one, no, I don't have the COVID-19 patient after bariatric surgery. Number two, I would believe with you that the number of flu infection should be reducing after bariatric surgery, especially the information from the report that the obesity would reduce or decrease the immunity. So I would think that I agree with you. Thank you very much.
Thank you.
David, I will touch on question number two a little bit in my talk, not related to flu, but extending that to COVID. However, we trust you that treatment of obesity and diabetes and its associated comorbidities should help prevent the infection with flu or bad outcomes with flu. And by extension, probably COVID.
Mm-hmm. As you know that the bariatric surgery is a little bit different from the other surgery, like a cancer surgery or others, because obesity itself is one of the biggest risk of the infection. But the bariatric surgery is one of the most effective treatment for obesity. So that we have to think the risk and the balance of obesity or bariatric surgery risk. So how about other opinion?
Yes, I agree. So even I have not seen any COVID-19 patients in the bariatric practice because our local population incidence is very low. So we have not seen. And for the second question, yes, but I think the effect of the flu is after the bariatric surgery. Once the patient loses weight and they've gone past the surgical phase, they've started losing weight, they've got the diabetes under control. That's when the beneficial effects of bariatric surgery starts kicking in, which I assume is around 6 months, 7 months, when they've lost more than 15-20% of excess body weight. But we can discuss this later.
Yeah, I think we're getting short on time, Kazu.
Yep.
Okay. So thank you, Kasama, for sharing your experience. And I just want to add a point for Kasama. Usually when we operate, when we want to edit the video, we make it 2 or 3 speeds, time speed. But when Kasama operates, it's already 2x or 3x speeds. This is what we say. Thank you so much. The next speaker is Dr. David Cummings from US. He is a professor of medicine in the Division of Metabolism in the University of Washington. He has obtained his medical degree from Harvard Medical School, and he is a recipient of Presidential Early Career Award for Scientists and Engineers, which is the highest award which is given, and he received this award at White House. And he has also presented his work in many universities, even to the Nobel Committee in the Nobel Symposiums. Welcome, Dr. David, and we would like to hear you on the DSS recommendation. Thank you.
Thank you very much, everyone. It is my pleasure today to talk to you about recommendations from the Diabetes Surgery Summit on the use of bariatric metabolic surgery during and particularly after the COVID-19 pandemic. Diabetes Surgery Summit and its associated World Congresses are a series of global consensus development conferences that have been going on every 2 to 3 years since 2007 and are ongoing, with the overarching objective to provide continuously updated and refined guidelines on the use of bariatric metabolic surgery worldwide. Our most recent project was to generate some recommendations for our prioritization system for how to manage bariatric metabolic surgery during and particularly after the COVID-19 pandemic abates, when there's a big backlog. We've just recently published this material. The authors of the subset of Diabetes Surgery Summit panelists and faculty, as well as a few people brought in because of special expertise in this new question. Someone in the background is speaking, and please mute yourselves. I think the people are speaking Japanese. We published our work exactly 2 weeks ago today in Lancet Diabetes Endocrinology. The authors, on purpose, were weighted towards physicians and internists rather than surgeons, about 3 times as many non-surgeons. DSS does this on purpose because we generally tend to promote bariatric metabolic surgery, and theoretically, internists and non-surgeons have less of a perceived or actual conflict of interest in doing so. So, as some of the other speakers have highlighted, there's an inherent sort of paradox when you talk about bariatric metabolic surgery and COVID. That is as follows. As we've discussed, people with obesity and or diabetes probably have a higher risk of contracting the SARS-CoV-2 infection in the first place, and they definitely have a bigger risk of suffering worse outcomes with COVID-19. However, bariatric metabolic surgery is the most effective treatment by far for both obesity and diabetes. So from a purely logical perspective, theoretically, we should be promoting bariatric metabolic surgery right now to reduce the burden of diabetes and obesity and protect people from bad COVID. On the other hand, surgery itself increases the risk of contagion for both patients and staff, not just because of the usual reasons, but because these operations involve several things that increase the dispersion of aerosolized droplets. So these include, for example, the use of pneumoperitoneum, electrocautery, ultrasonic shearing, and upper GI endoscopy. And our group quickly decided, after our literature search and expert opinion, that these immediate risks of contagion to patients and staff outweigh the theoretical benefits of metabolic surgery to reduce COVID-19 bad outcomes. So we agree with other societies and other speakers so far that this, like all other kinds of elective surgeries, should be suspended during the peak of the COVID pandemic. Hence, we spent most of our time and effort in this paper trying to develop a triaging system for how to manage COVID-19 patients and prioritize them once elective surgeries begin again. Because eventually COVID-19 is going to abate, and then at that point there'll be a huge backlog of patients that are seeking metabolic surgery. Delays in that surgery from the backlog and limited resources will harm some patients more than others, and that's going to depend on individual burden of obesity-associated diseases that would cause comorbidities and mortality and death, and the likelihood of surgery to reduce those. The ages-old NIH criteria for surgical selection based entirely or almost entirely on BMI really don't get at this question. So what the DSS subgroup did was to offer a strategy for how to prioritize metabolic surgery when the COVID-19 pandemic goes away, based on the burden of metabolic diseases most likely to cause harm if surgery is delayed and most likely to be benefited by surgery. We quickly defined 3 classes of surgical prioritization. Some of the other speakers have talked about this. Urgent access would be given to people with immediate complications. Typically, this is some sort of complication from a prior operation you've had. And then most of my time I'll spend on defining the difference between expedited access, which we define as surgery required to be done in 3 months, or standard access where people can wait around for maybe as much as a year and not be at the front of the line while we're clearing out the backlog. So this is our algorithm that we put together for prioritizing use of metabolic surgery once elective operations begin again. First, we define bariatric metabolic surgery as being divided into 3 different categories based on the indications. There's first diabetes surgery, where the primary goal is to get rid of that disease, and then obesity surgery, where you're primarily trying to promote weight loss, and lastly, adjuvant bariatric metabolic surgery, which I'll define in a moment. In each case, we categorize priority to access into either that which requires expedited use or standard access. So for example, and those things are determined by the patient's conditions. So for example, in diabetes surgery, characteristics of the patient that would warrant expedited access include the following, and these are basically all features that have been shown to increase morbidity and mortality from cardiovascular and other events. So for example, a very high A1C of greater than 8 on at least 2 oral medications has been clearly shown from DCCT edict and UKPDS to be associated with both microvascular and macrovascular complications. Insulin usage is clearly shown, especially from the TRIAD study, to be associated with increased mortality, so its usage would be considered a reason to be expedited, have surgery expedited. Obviously, a history of prior cardiovascular events actually happening, the presence of NASH, or at least 2 other metabolic conditions such as hypertension and dyslipidemia are all associated with increased risk of cardiovascular events. Albuminuria and or stage 3-4 chronic kidney disease is a superb proxy for the risk of cardiovascular events. So that would be another criterion for expedited access. And diabetes duration of 5 years, the reason we put that in there is because it's clear that after about 10 years of known duration, you start having a real fall off in diabetes remission even after metabolic surgery. Many of those conditions would warrant expedited access when the backlog starts getting cleared out. And the absence of any of them would be consistent with standard access being okay. Those folks could wait around for a year and not be harmed nearly as much by the delay as the more sick people metabolically ill. How about if surgery is primarily being done to reduce body weight? Well, the same idea applies. Expedited access versus standard access is determined by the presence or absence of conditions known to be associated with increased mortality. So people with a BMI over 60, for example, have been clearly shown to die more than those who have lesser obesity. Once again, the presence of NASH or other metabolic conditions that are associated with cardiovascular risk, such as hypertension and dyslipidemia. It's clearly shown that severe pulmonary disease like obesity, hypoventilation syndrome, and or bad obstructive sleep apnea are associated with increased mortality, so they would warrant expedited access. The presence of heart failure of American Heart Association class C at least, not bad enough to make you not a surgical candidate, but bad enough to make you more likely to have death if you don't get treated for your disease quickly. And again, stage 3 chronic kidney disease is on this list. And if you don't have any of those things, then you can wait for standard access and not be at the front of the line. Adjuvant metabolic surgery is anything done to allow the operation of a different type of surgery. For example, imagine you're dying of some end organ disease and need a transplant, but you've got to lose a lot of weight before that. That would be a compelling reason to have quick bariatric metabolic surgery. Or if surgery would enable other time-sensitive treatments that are critical, such as coronary artery bypass graft, major hip replacement or knee replacement, all of these would be considered reasons for expedited access to surgery. So to summarize, we propose that after the COVID-19 pandemic, when we're trying to clear out a huge backlog with limited resources, patients should be prioritized for surgery based on their burden of diseases most likely to cause harm to them and cardiovascular events and be ameliorated by surgery rather than based on PMI. And probably the most important thing I'd like to say is that although this triaging system and the principles behind it are particularly germane when we're trying to get rid of the expected backlog of patients shortly after the COVID-19 pandemic, there is no reason why the same principles can't be used as a meaningful guide for prioritization long into the future instead of using BMI as the primary criterion. And as I said, we published these results 2 weeks ago in the current issue of Lancet Diabetes Endocrinology, and I welcome you to go see that paper. Thank you all for your attention.
Thank you so much, Dr. David. Your words always bring wisdom, and you have done an extensive research on this recommendation. I know that, and I congratulate you for the publication in the Lancet. We'll take the questions at the end. And now we have Dr. Mohan Ramchandani. He is a senior consultant and director of interventional endoscopy at AIG Hospital. He is a well-known figure in all advanced interventional endoscopy like POEM, ESG, and ESD. I would like him to give us some thought process on what are the guidelines for endoscopy and what are the procedures he can perform in a post-operative bariatric patient or altered gastric anatomy patients. Over to Dr. Mohan Ramchandani.
Good evening, and thank you, Abhishek, for your time and wonderful opportunity to interact with some of the best guys available in the world in the field of bariatrics. I am an endoscopist, and it was heartening to know from the experts from the world, especially Asian countries, how they are fighting with the COVID, and they have successfully contained it. In India, the situation here is that we are 1.3 billion people, and we are still struggling, and number of cases, though related to our population, is less, but still it is around 150,000, and we have around 4,500 deaths, and we at present are facing around 6,000 to 7,000 new cases per day. As an endoscopic unit, our unit is a very busy unit, and we do a lot of endoscopic bariatric procedures and also simultaneously tackle the issues which comes up in the patient who have already undergone bariatric surgery and comes with some complications. So majority of our cases now are those patients who come to us with some complication, but the elective endoscopic bariatric procedures are almost we have stopped for the time being. As far as endoscopy and COVID is concerned, we should know that what is the risk and how we are overcoming it. What are the precautions which we are taking during, before, and after endoscopy, and we'll definitely talk about how we are tackling some of the complications which are very urgently need to be tackled in patients who have already undergone bariatric surgery. So the risk in the COVID era by endoscopy is definite, because endoscopy is an aerosol generating procedure, and the positive insufflation which we do causes the risk to be increased by generating the aerosol, and there is increased risk of viral transmission. So endoscopic persons are definitely at risk, and the virus definitely spread by close contact and aerosol droplets. Not only the oral endoscopy, but also the colonoscopy is associated with risk, because the RNA of SARS-CoV virus has been detected in feces, and stool shedding can also persist even after the clearance of virus. So colonoscopy is also a procedure with a definite risk involved of the spread. We as an endoscopic societies are working on this, and there are many guidelines which are available now with us, especially from Italy. And then we had a Asia Pacific Society for Digestive Endoscopy coming with COVID statements. And also we have seen our society, namely the Society of GI Endoscopy of India and Indian Society of Gastroenterology, coming up with many guidelines and statements guiding the society to how to schedule your cases, how to cut down your cases, and what are the precautions which we should take during the endoscopy. And as the community spread is going up in India, we now have significant number of asymptomatic patients coming to us for endoscopic procedures, and we need to have preventive measures necessary to avoid massive endoscopy related virus spread. For this, what we do is we now stratify our patients and classify them based on the symptoms, their contact history, and stay on the low risk, intermediate risk, and high risk. The patient who have no symptom, no contact, and no stay in high risk area are low risk, while those patients who have symptoms and either contact or stay in the high risk area are known as high risk patients. And based on these symptoms, which we call as fever, travel history, occupation, cluster, and contact, we divide them into the symptomatic patients and those who are symptomatic, or those who are high risk patients. We offer them COVID test, and then if COVID test is available, we do it, and if they are positive, we call them as high risk patients. And those patients who are symptomatic but COVID test becomes negative. But COVID testing is not uniformly available in India, and there are the health is a state issue. So we have many states which have got different laws, and the testing also is not uniformly available in India. So there are many places where the test may not be available for the people, for asymptomatic people, or for elective procedures. And if they are not available, we still tell them, we include them as high risk and treat them as if they are already infected. And we have also divided our endoscopy in emergency or urgent based on their presentation. And then we decide whether, based on their COVID testing and symptoms and contact, whether they need only urgent endoscopy, or whether we can do elective endoscopy, including urgent, semi-urgent, and elective cases also. The urgent endoscopy are limited to the GI bleeding, like upper and lower GI bleeding, those who are coming with perforations, and those who have dysphagia, like a foreign body infection, those who have cholangitis and shock, this symptomatic pancreatic collections, and non-surgical cholecystitis, where we need to do drainage of gallbladder, the GI obstruction, the cancer evaluation is also now we are including in patients whom we cannot avoid the delay because obvious reason of the upstaging of cancer. And based on this, we now are delaying our routine endoscopy, like upper GI screening for assessment of varices, colonoscopy screening, surveillance, interval endoscopy, and so on and so forth. So these are the things which we are avoiding. And we have changed our endoscopy suits, and you can see here the endoscopy suits are now more looking like operative rooms, and we are doing innovations in the masking, how to reduce not only the PPE the doctor is getting, but also the patients. We are now innovating and then trying to bring as far as possible the barrier between patient and the endoscopy. You can see the face shields and how the endoscopy is done. We are more careful in exchanging the accessories, not allowing any the water or anything being leaked. We keep on sucking out all the patient, try to do all the procedures under propofol, so that there is minimum retching, minimum aerosol generation, and the endoscopes and also the disinfection is being more stringently followed. All the accessories and all that the disposables being very strictly followed in our endoscopy suits, and more this type of things were not, they are not very strict as a OT, and our now endoscopy suits have almost converted like an operation theater. So in nutshell, we divide our patient as high risk or low risk, and then our procedure as urgent or non-urgent. And based on their presentation, we decide whether the urgent procedures needs to be done. But ultimately, as you saw, we were locked down for 2 to 3 months, and then now because of the economical issues, we have to open up. Though the resumption is gradually occurring, the state-wise, there are almost some states which has shown that the cases are now decreasing. Some states are not showing that trend, but based on the states, the endoscopy suits and hospitals are taking their decisions, and patients are now being offered at PCR-based testing, and based on that, if the test is not available, then we are concentrating more on the high degree of PPE, and that if the test is available, like positive test, then we are trying to postpone the procedure or move to the inpatient setting. And if the test is negative, then we are doing all the routine procedures now also in standard PPE. So gradually we are opening up, and we are now also, as an example, I'll tell you this some patients are also like this patient, because this is a bariatric club, and I am being endoscopist. So during this peak of pandemic, we get patients who have undergone bariatric procedures, presented with fever and jaundice, cholangitis, shock. These patients need urgent care, and these are the procedures which we need to do in a very urgent situation. You can see this is a single balloon enteroscopy guided ERCP being done in a patient who has come to us with shock, and you can see we have with very difficulty could reach to the papilla through this afferent loop, which was pretty long, and then doing the ERCP in a reverse direction, cannulating pancreatic duct, and then achieving the cannulation and then balloon dilatation of the papilla, and then removal of the stone. So this is these type of procedures are very rewarding, very urgently required, but with all the PPE and judicious use of the tests which are available, we are managing. And I'll stop here because of the want of time, and I'll just thank everybody for patiently hearing endoscopist view in an elite group of bariatric surgeons. Thank you so much.
For covering most of it in a very short span of time. So we would like to conclude this meeting. There are so many questions which are coming up, but due to short of time, we won't be able to take all the questions here. I would just like to share one or two slides of mine, which are the Aussie guidelines from Obesity Surgery Society of India, and most of the points have already been covered by all the eminent speakers which we had, and I'm thankful to all the committee member of Aussie who made this possible and the guidelines were issued. My only concern is I want to conclude my slide with is bariatric surgery is an elective surgery. Most of us know that people consider it as a bariatric surgery as an elective surgery, but I would say, what if today's elective surgery becomes tomorrow's emergency? And what if delayed elective surgery today is a reason for tomorrow's life-threatening situation? So, we all disagree with the concept that bariatric surgery is an elective procedure and bariatric surgery is a life-saving surgery with survival benefit. Also, we know that COVID is more severe in BMI more than 35. So we have to understand that bariatric surgery, even though it's elective surgery, but we should consider it as a semi-emergency because it can save somebody's life, and you as a bariatric surgeon are the captain of your ship, and think wisely and prepare for storm. Thank you. And I would like Dr. G.V. Rao to conclude this meeting.
Thank you once again. At the outset, let me thank all the speakers from across the globe, giving a global perspective of what is going on across the globe. We are very thankful, the viewers are very thankful for listening to all the views from different parts of the world. We also understand that actually, because bariatric surgery being purely a laparoscopic procedure, because I'm a laparoscopic surgeon myself, but there are a lot of limitations that are laid down to do these laparoscopic procedures. So I think, but if you see the new evidence that is coming up in, actually most of you might agree that if you have seen the latest publications that have come in that have shown that laparoscopic surgery is equally safe as compared to open surgery. Now it is not that laparoscopy is any dangerous as compared to aerosol generation as far as we take all the precautions concerned and all the equipment that we have. The only limitation to doing laparoscopic bariatric surgical procedures would obviously be that you are preparing yourself for any emergencies which arise in the COVID era. That is the only limitation I think we have as in today. But there are several specialties that are raising their voice as in now. The oncological societies are raising their voice to see if oncology procedures can be done, because these patients seem to be progressing in their stage. So I think even obesity, I think it's a pandemic actually. I think we have to have some guidelines, maybe I think in the next few weeks, few months, we'll have more guidelines coming in, showing that some of these patients can be taken up as a semi-elective procedure, if not as an emergency. I think the panelists will agree with me that in the days to come, we'll be seeing some bariatric and metabolic surgeries being done. A select group of patients at least, I think, should undergo these procedures even during the COVID era. Thank you so much again. And as we keep getting questions from all this, we'll mail it to the concerned panelists and then mail it across to the viewers who have raised these questions. Thank you once again. And again, our sincere thanks to all the societies who have endorsed this meeting, the Endoscopic and Laparoscopic Surgeons of Asia, the International Bariatric Club, the International Excellence Federation for Bariatric and Metabolic Surgery, and the Obesity Surgical Society of India. We are sincerely thanking all the executive members who have endorsed this meeting. Thank you very much again for joining us in this webinar, which is done from panelists from across the globe and is relayed live from AIG Hospitals, Hyderabad, India. Thank you so much.
Thank you so much. Thank you so much, all the faculties.
Thank you very much.
Yeah, thank you.
How about you, Sudeb?
Hi, thank you. Thank you very much.
Hello,
Hey, David, thank you.
Thank you so
Looking
much.
Good.
Hi.
You guys thought it was